Well, hello, I'm Jennifer Blomquist. Thanks so much for joining us tonight on HealthLine. I have the privilege of hosting the program this evening, and I'm so glad you joined us because it doesn't matter what topic our focus of our show is each week, you are guaranteed to learn something and get some free advice. Since nothing is really free today, why don't you take advantage of that? We are delighted tonight to have a returning guest. He is an orthopedic surgeon, and he brought a whole bunch of props of equipment and tools that he actually uses on patients, and so I think you'll find that fascinating to actually see all the advancements in this field. We're talking about joint replacement tonight. So here's how it goes. In case you're new to the program, we are live here in the studio, and we are more than happy to take any questions you may have for our guests tonight. So that's why we keep that phone number up throughout the program. It's 969-2720. If you're outside of Fort Wayne, it's still a free call because everything on this show is free for our viewers. It's 866. Put that in front of that number and we'll get you through. You can ask your question live on the air. They do not just throw you on the air. You will talk to a call screener, a very nice lady, and she will talk to you, and then you can ask the question live, which I like because you can talk to the doctor, you can go back and forth, and maybe, you know, he needs more information from you to better answer your question. So that's a great option. But I also appreciate that some people might not want to do it that way. So just tell the call screener what you'd like to know, and she will pass that along to us here in the studio, and we'll get your question answered that way. So without further ado, let's go ahead and introduce you to our guest. You may have seen him before, Dr. William Berghoff, who is an orthopedic surgeon, and I mean, half the desk here is all of his props that he brought with you. Thank you so much for doing that.
It was my pleasure to come, and I always bring my props because my patients always want to see what it is, just inside their body, and it's a good way to get to know what we do and how we do it, and it was a pleasure to bring them in.
Yeah. And you wanted to talk, well, you know, and that's the thing is this is something that you and other professions in this field deal with every day. But for a lot of us, it can be a little scary or daunting and thinking, okay, what are you doing and what are you putting in there and what does it look like and how does it work?
Yeah, and we have this model of the knee in our office, and patients still come in and ask and think we're going to chop here and here and then put new bone in.
Oh, goodness.
So it's good to always have the models and show everyone exactly what we do. And I brought my notes today because I always forget to say things when I come to this show. And
well, it goes fast, and we always get a lot of calls, which we love. In fact, we're getting one coming in right now that we're going to go to in just a second. But you were primarily wanting to focus on hips and knees
hip
tonight.
and knee replacements. And we did, as a country last year, we did about 2.4 million replacements. Primary hip and knee replacements. About 1.3 million of those were total knees.
Yeah.
And about 825,000 were total hips, and then you have a few hips and knees replaced for fractures and other things. So, and interestingly, about 58% are in women, and the other remaining in men. And so, you know, those are big numbers, and it's growing.
Oh, yeah.
We grew as an organization, the American Joint Registry. We grew about 14% year to year. So orthopedic replacement it's gaining steam, and it's getting very popular, and we're seeing a lot more.
I was going to say, people are living longer, and like I look at my parents who are in their mid-70s, and they don't look old to me. My dad's still out, you know, active. He's still running in half marathons. You know, my mom's still out doing her gardening, and my dad actually had some knee issues and had some surgery on it, and he's good as new and back to doing, you know, what he loves doing. And so I think that's part of it. Maybe is just I don't remember my grandparents living that kind of a life. You know?
I think people today are more interested in their health.
Yeah.
And, you know, certainly shows like this that promote health, healthy bodies, healthy minds. They live longer.
Yeah.
And, you know, look at the range of patients in my office. I think the youngest I've ever operated on was a 22-year-old.
Okay.
And she had rheumatoid arthritis. And then the oldest, you know, I've operated in the 90s.
Wow.
2 years ago, I had a 10-year recheck for a patient I put a total hip in when he was 94.
Oh my goodness!
So he came in at 104. And we had kind of a big deal in the office.
Yeah,
and he,
God bless him.
But he was in great
my
shape.
gosh.
And if you're in great shape and your, you know, mind's good, heart's good, you know, joint replacement, you can do it into the 80s and sometimes 90s. Yeah.
Age is just a number, right? I just had a birthday yesterday. That's why I'm in that frame of mind. So I want to go ahead. I don't want to miss this call, doctor, because this person's been waiting very patiently. I think this is it Patricia? Is that correct?
Yes.
Hi, thank you so much for waiting. Go ahead and ask your question.
Hi, I was wondering, can you run and jump when you have an artificial joint?
That's a great question. And, patients always ask us going into it if they're going to have to give up anything if they do get an artificial joint. Prolonged running, jogging, we kind of frown on. It's just a cyclic manner that you load the plastic time and time again. It doesn't do the joint very well. You can jump occasionally, but basketball, probably not a good idea. When we tell all of our patients, as long as there's not a lot of twisting, turning, get back to sports. I let them play doubles tennis. That's kind of the upper thing. And being a skier like myself, I let them all ski. I'm a little biased with that. But they can get back to a lot of activities. There's new developments coming out where some of the knees they're starting to look at having shock absorbers or something built into them. That's maybe a real frontier there. And with that, we could probably say we could let them do more. But right now, no high impact, repetitive high impact. And, anything that's on and off is great.
All right, Patricia.
That's a good question.
It was a good question. Did you want to ask anything else before we let you go?
No, that was it, but thank you so much.
Oh, thanks for calling. Appreciate it.
All right.
And if you want to do the same thing Patricia did, which is great, again, it was nice. She could kind of interact back and forth with Dr. Berghoff and get more information. Do it that way, or you can call that number at the bottom of your screen, 969-2720. Call that number, and you can just relay your question to the call screener, and they'll give it to us out here. Either way, you get your question answered. So.
Sure.
You were talking about those shock absorbers. I didn't think about that. Is that something that...
It's new materials. We have to wait for the material. Is this 10
years away, do you think? Or does it take a while to research that?
They're still testing on that stuff.
Yeah.
But, if you would have told me we could have a custom knee made for an individual when I started my practice.
Yeah.
I mean, we were just starting to make right and left knees when I started. That's how far back I go.
Yeah.
And now we're into the field where we're using robotics, we're doing navigation, we're making custom knees. The field has just expanded with technology. And, hopefully someday we kind of get to that point where we can let people be a little bit more active.
I remember years ago, I did have an aunt. She's since passed away, but she had rheumatoid arthritis and had surgery on her knee, and it just looked agonizing. I mean, she was out of commission for like 6 months. Now, this is going back 30-some years ago, and now I meet people and they'll say, well, it was outpatient, or, I was down for a little bit and doing physical therapy. I'm amazed at how much the recovery time is cut down.
Yeah, about 90% of the people go home back to their living environment. If it's safe, if they have someone that can help them.
Sure, yeah.
And maybe 10% need something like a nursing facility or a rehab.
Okay.
But we encourage them to go back to home because, home's the place to be.
Yeah.
And you're encouraged to get up and walk more and probably get a little bit better care. So, last year we sent about 90% of them home. And the other thing, too, is we really get them in the office, we get them in therapy, we get them kind of tuned up before surgery.
Okay.
It used to be we would just do surgery and then they were in the hospital for 3 days and then excruciating physical therapy. And now we get them up the same day. Some of the patients are discharged the same day.
I've heard that even about hips.
Hips
you're standing.
and some of my knees
night.
I discharged. I discharged a few this week to home the same day of surgery.
Okay.
And that's, anesthesias have really helped us a lot with they do the spinal anesthetic and then they do regional blocks. And with the newer techniques, we really feel like we're making progress into getting people out of the hospital a little bit earlier.
I think it's less scary when you hear about it that way, like, okay, my recovery's not, it's not going to be pain-free, but it's going to be different than maybe what we used to associate.
Absolutely. And if you tell someone there's an option you can go home the same day, then, it kind of puts things in perspective. It's really not going to be that bad.
Yeah.
Yeah.
Sounds like a big improvement. We had another person call and want to ask you a question. I believe this is Woody. Go ahead, Woody.
Yes, this is Woody, and yes, I was calling. I had a knee replacement, and I'm trying to be active and everything. I go to a lot of ball games, like football and basketball, and I climb the stairs and everything. Is it okay? How far should I push it that way or whatever? And the question two, have you ever done a hip and a knee replacement at the same time?
That's interesting.
Wow, those are real good questions.
Yeah.
As far as getting back to activities, I think you're right on when you say stair climbing. I think stair climbing is the hardest to get back with the knees.
Is it?
It's that
Okay.
quadriceps function.
All right.
And that can take up to 6 to 8 weeks to get back. But walking, and we get them walking the same day.
Okay.
And then there's this progression, and the last part of the progression is probably stair climbing.
Is
So
that something?
what Woody hit on right there is
Yeah.
he must know is that it's difficult to get that stair climbing back. And the other thing is a lot of elderlies don't have stairs.
That's true.
So they
yeah,
can't
wanna
really
live in a single
practice
floor.
what they're
Yeah.
doing, but they get around great without much care at home on one level. So
Is it okay to do that? Like if you had stairs and you've had a knee replacement, is it okay to use them? I mean, should you use them minimally, or is it okay to use it as much as you want?
as much as you want. The other thing is that most of the needs go to therapy.
Yeah,
And the
that's
physical
true.
therapist is the other half of this whole equation.
Sure.
You have to have good physical therapists that push the patients,
Right.
that progress them as they progress. And they usually have stairs in their offices.
Yeah,
and,
I've
and
seen
so,
those, yeah.
they have little
Little
fake
steps.
set up.
Yeah.
And so that once they accomplish the stairs, then they say, okay, you can probably go up and down stairs without somebody assisting you.
Okay.
And, we always make sure they have a good banister and other things, but the physical therapists are really the ones that kind of moderate that.
Yeah.
They do a great job.
I was say it's a team effort anymore. I mean, it's your nurses, it's your doctor, it's the physical therapist, all
Yeah.
working together. So.
Yeah, and then as far as a knee and a hip, I've done one.
Did you?
Yeah, and I promised myself
simultaneously?
I'd never do it again.
Oh, really? Can I ask, like the relative,
Well,
the relative age of the patient?
Yeah, he was younger.
Okay.
And they were kind of related together. His bad hip played right in. He had a really deformed hip that played into his knee,
Okay.
and it was coming up on an insurance thing, losing his insurance. So
Gosh.
he got on the better side of me.
Yeah.
And convinced me, but I've done it once, and it was successful. But
Same
probably won't
side
do
of the body? Was it the
It was
same side?
yeah.
Okay.
And then you
so-
have to
okay.
redrape, and then you bring up other things that can go on with the redraping and things
Right.
like that. So prolonged
Yeah.
anesthesia, obviously.
Oh, right,
Yeah.
sure. My
So,
goodness.
So thanks, Woody. That's interesting.
It can be
question.
done. Yeah, it can be done. I don't know if you
Brought
want
up
to
a
do
sore
it.
point there.
Yeah, a bad memory, I guess. So, all right. Well, thank you. Those are great questions. And again, we just have Dr. Berghoff here for a short time, just until about 8 o'clock. So call sooner rather than later. We end up having that issue where people wait. So call sooner. Like I said, there's 969-2720. That's the number, and we keep it up at the bottom of the screen throughout the program. We did have someone who wanted me to ask the question for her. So a woman named Sylvia. She said, why can you not just replace knee cartilage or I guess why can't you just replace knee cartilage when the knee is bone on bone?
Oh, that's so.
What do you do when you're in that situation?
When you're bone on bone,
Yeah.
it's more global.
Okay.
And so all these condyles, the entire knee is worn out. What our sports doctors do, if you have an injury to a certain area, maybe a centimeter by centimeter in the cartilage,
Okay.
they can go in and they can put a scaffolding of cartilage in there, and it will grow. But you have to have a surrounding cartilage around it that can support it. And when you're bone on bone, it's the whole knee is shot. The difference is between filling a pothole and resurfacing the whole street.
I see.
And
Okay.
and what she's asking is
Why can't you
the
just fill
whole
the pothole?
street. Yeah.
Okay.
And
Yeah.
the other thing interesting is when you get arthritis, everyone thinks it's cartilage, but there's subchondral bone that supports the cartilage underneath. Think of a mattress. You have
Yeah.
your mattress and a box spring.
Right.
And as you get arthritis, this subchondral bone changes. It becomes a lot stiffer. So even if you were to put cartilage back on top of it, it wouldn't have the same support
I see.
that normal bone would, and it would be
Okay.
more apt to wear out. The real cure on all this is probably treating the subchondral bone and the cartilage so they don't break down over the years.
Now, that looks, what you have in your model, the knee replacement, is that like a certain kind of plastic? And is the metal part, is that titanium steel?
So this is one of our more custom knees, and
Yeah.
all knees basically look like this. The custom knee is just made for you. It's
Okay.
like you getting a tailor-made suit instead of one off the rack.
Right,
It just fits you
right,
better.
sure.
And this is usually cobalt chrome,
Okay.
polyethylene, and this is usually a titanium
Oh,
substrate.
okay.
Yeah, and so where you're bone on bone, now we got a sandwich. We got this plastic in between so the bones don't rub together. And that's basically what a total knee is. And if you look at the side here, we're only removing about 5 millimeters of bone, not chopping the whole knee here off.
Yeah.
And it's milling more than anything else.
And that's, do you how invasive is it now? You talked about robotics robotic surgery playing a role. Can you do a total knee replacement robotically?
No, robotics, with the way the general surgeons use, is smaller incisions. Our surgeons use robotics and navigation to check their alignment and to make the cuts. It's basically the same incision.
Okay.
It's more a way that we can use to check our cuts and to make sure that the knee's properly aligned.
Yeah.
There's 3 things in the surgery. Obviously you have to make the exposure, then you have to make the right cuts, and you have to put the implants in the right alignment, and then you have to balance these ligaments. That's the other thing. You got to do some balancing. So there's a lot going on.
Yeah.
And the robotics is just one way that some of our surgeons use it to check their alignment.
Sure.
Yeah.
Very involved. Gosh, the screen is just lighting up here, so I don't want to forget to answer some of these questions.
Halftime on the basketball
I kind of feel like I kind of half answered Jacob's question, but go ahead, Jacob. You were asking about custom knee replacements.
Yeah.
Go ahead.
Hi. I was curious about the custom knee replacement. One, I guess, how does that work? How do you get a knee custom just for me? And then the benefits of going to maybe a seasoned surgeon that wants to do a custom knee surgery, or maybe a newer, younger surgeon that maybe wanted to try it for the first time.
Well, the custom knee is, here's the easiest way to think of it, if you can see this. If I put a caliper in surgery and I measure this as a size 4, then I get a size 4 in this direction automatically. Their two are married together, okay? And your question, Jacob, is a custom knee. If I could say this is a size 19, I can put a size 8 or 9 or 10 or whatever I want in this direction. So it addresses this side and that side. And realistically, get kind of the same knee you had before you got the arthritis in it. And that the thinking there is it feels more natural. And some people say that knee doesn't feel right, or it clunks or does this. I think your chances of getting it just right is the same as if you go to a tailor and get a suit made just perfectly for you, and instead of off the shelf. It's a personal preference, and you can get both knees 20 years and have fantastic results. Yeah, but the thinking is just maybe one just feels a little more natural, and that's a benefit. And I did bring two custom knees here, and I'm going to say, okay, this might be the Jennifer custom knee.
Okay.
Just so people understand,
special.
and then
this is awfully heavy.
it is, and that's why I wanted you to pick that up.
Oh my goodness! Wow.
And this would be like
It's like a paperweight.
This is the Dr. Berghoff, of course, my size custom knee.
Yeah, look at that.
And they all come in different sizes, but
Hold it for camera 3.
I think the big thing is when the patients do pick those up.
I'm shocked.
Yeah, well, it has to undergo millions of cycles through your lifetime, and
Sure.
and it has to hold up to all the activities. Like your caller called in, jumping and running, you're still okay. It'll hold up. It's it's the plastic, the metal hold up. It's the plastic that kind of wears out over time.
Well, you had mentioned 20-year life expectancy for the hardware. Is that kind of a uniform?
If you drive it
number?
right, you're going to get 20 years.
Okay.
If you go out and start jogging, you might not get 20
Maybe
years.
not. Okay.
I have people in the office, I see 20 plus years that have taken care of their joints and done what I told them not to do, obviously.
Right.
And they've done really well.
Gosh, yeah, I wish everybody at home could feel this. I am really shocked. It really is. It's like as if you picked up one of those, those big circle glass paperweights that you'd have on your desk in an office. I mean, that's what it's like comparable weight-wise. Yeah. So I'm going to go ahead to another phone call, if you don't mind. And I please apologize. I'm not sure if I am pronouncing this right. Is it Teague or Teague?
It's Teague.
Teague. Okay,
Yeah.
I'm so sorry. Go ahead with your question.
Yeah, I've have friends that have had knee replacements. We've had discussions like with his name's Monty, and one's Matt and Tom and Jason, and with all the different available companies and different implants that are available to you, how do you make a decision with computer assisted, custom, what are some factors that go in choosing what implants you would use for a patient?
Well, that's a good question. First of all, is patient activity.
Okay.
You know,
Yeah.
maybe younger or more active people, higher performance people, more demanding, need a more demanding implant.
Sure.
And for that, you know, we make that choice. For someone less demanding, they might not need the benefits of necessarily a custom knee, but the knees we put in give them exactly what they want: pain relief, restorative function. They can do the stuff they want to do, you know, visit the
Yeah.
grandkids, play
Oh,
golf.
yeah.
They can do all that stuff, but maybe they don't want to go out and climb a mountain or ski, you know.
Yeah.
So we try to match the patient implants with the patients. And what we're running into a lot of times now is the insurance companies are pushing back on what we can and can't do. And, you know, we try to fight for the patient as much as we can and get them
Sure.
the best product that they can. But it's like anything else in life, you know, it's a constant battle.
Yeah, that's interesting. I mean, at least I guess you do have choices. That's the one thing. Is,
Absolutely.
you know, there are a number of products out there. So,
Yeah.
Teague, did you want to ask anything else?
Nope, that's it.
Okay, great question.
Thank you for your time.
Oh,
Thanks
thank you
for
so
calling
much.
in.
Have a good night. Thank you. We also had somebody wanted to ask you a question. It was Wesley, and wanted me to ask for him. So he said, can someone with a joint replacement get an MRI?
Oh, yeah.
I wonder, because I know with braces, like when our kids had braces, they said they couldn't have an MRI.
Yeah, so they can get an MRI. Usually it's more with the hips. The hips are
Okay.
mostly titanium.
Yeah.
The knees are cobalt chrome, and so they're a little bit ferromagnetic.
Okay.
And so you get scatter. If we want to look at a total knee or anything around a total knee, they can get a CT scan.
That's a better, clearer picture that way.
And it's not magnetic, and it's
Okay.
not interfered with by the metals.
Okay.
So both of them can do imaging studies. The hips more of the MRIs.
Okay.
And the knees with the cobalt chrome, which you picked up and found
Yeah.
pretty
Oh
heavy,
my gosh, yeah.
just get distorted with the MRI, so they get the CT scans.
Right.
Yeah.
Good. Yeah, that was a great question because I've always heard that if you have anything metal, that can
Yeah.
distort the picture.
But if you get you know, Wesley, if you want to get an MRI of a different part of your body, other than where the joint is, you can do that. It's not like there's ever enough magnet to pull or
okay.
disrupt it. Like a pacemaker, obviously you can't for some of the pacemakers, but with the joints you can, because they're not going to go anywhere.
Right.
They're in there rock solid,
Okay.
and they're not going to be moved by the magnet either way or another.
Okay.
Yeah.
No, it's a great question. See, I'm going to try and quickly get this one in. Barb is asking, what are the steps in a knee replacement, and how long is the recovery? We kind of touched on that a little bit earlier about how you can be, you can be discharged the same day as your surgery.
Yeah, you know, it all comes down to two teams. We have a team in the office,
Okay.
you know, my nurse, Katie, and her team, and they get the patients ready. And then we have patient educators at Parkview that make sure your lab work's all done, and that's a chore and a half nowadays.
Sure. Oh, yeah.
And then Mindy's our educator. She sits down with the patients and gets them all ready for surgery. And then behind all this, you got physical therapy getting them ready for surgery.
Yeah.
And then when you get them to the hospital, you got, you know, pre-op, post-op, anesthesia.
I mean, it's a
And then if they do stay
investment,
up
yeah.
on the floor, it's, you know, everyone knows me as a joint doctor, but I got to tell you, I got the greatest team
yeah.
around supporting what I do, and it makes it easy for me to do this.
I hear that all the time from patients, whether they have cancer or they're having something orthopedic done, is they'll say, like, I had a great team, you know. And when I was growing up, that wasn't it, you know. If you needed if you had a problem, you know, your family
Yeah.
doctor might send you to another doctor, and they might send you somewhere else for physical therapy, and then you might do, you know, something else with another office.
Yeah.
And you know, the communication, it's hard to communicate
Yeah.
when you're all split up like that.
Yeah, and I have a PA that's been with me 22 years and a great first assistant. I swear if
Yeah.
I drop dead, they finish the case.
Well, many of your colleagues have said that. You know, it's nice to have the PAs. So, I don't think we have time to take John's question live, but John, I hope you're listening. He wanted to know: is joint replacement help if you have one leg that's shorter than the other?
Good question. You can correct the leg lengths more easily with a hip than you can with a knee.
Okay.
The knee we can, well, if you're bowed and we straighten you out, you're going to be obviously longer.
Yeah.
But we can correct leg lengths with the hips by far a lot easier than we can with the knees.
All right, Interesting.
It's a good question.
Wonderful questions. Just a wonderful night. I'm glad everyone's staying inside and watching us and not out in this terrible cold. So, Dr. William Berghoff, thank you so much. A pleasure as always.
My pleasure. Thanks for having me back.
Come back with all the accessories again. That is extremely helpful. We love having that. So
Thank you.
Thank you. And again, thank you to all of our viewers for watching and for your great questions tonight. Hey, I want to remind all of you that they're putting clips of the show on YouTube now. So if you'd like to look at some highlights of this show or any other HealthLines, you can do that. We just started that about a week ago. So take advantage of that. I'm Jennifer Blomquist. Have a great night. And again, be safe, stay warm, and we'll see you next Tuesday. Mark Evans will be hosting a show. Take care. Bye-bye.
The preceding program on PBS Fort Wayne was made possible in part by...
It's a new day at Parkview, another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.